So welcome to a whirlwind tour of FHIR resources. My name is Virginia Lorenzi. I am your tour guide today. I work at New York Presbyterian Hospital. I'm a lead technical analyst. That's a recent title change. I don't know, they just keep switching my title. And I have another job. I also work on the faculty at Columbia. So where am I taking you? Well, you know, if you were in my hometown, we might get one of these big double-decker tours, and you know, you paid for the 45-minute tour, so we can't see the whole city. So we're going to take a tour. We're going to look at foundational resources, and we're going to look at resources related to the healthcare process, kind of administrative and clinical. And then we're also going to spend some time as we're doing that to kind of pull off to the side and look at tricks you can use on how to read any resource that you can apply that'll make the spec just much more easier to interpret. So our learning objectives for today are to summarize resources defined in FHIR that are foundational, that support healthcare administration, and support clinical process, all related to clinical process. And then we're going to spend a little time also while we're doing that, looking at some tricks so that you'll be able to interpret individual resources. You'll be able to describe common resource notations such as views, icons, and flags. And you'll be able to utilize these little resource nuances and hints such as maturity, examples, and patterns. And you'll be able to explain how resources relate to other resources. And we're going to tease out some of those key relationships in the FHIR spec. And then, you know, DevDays, when you're at DevDays, with every tutorial you're in, I think that every tutorial instructor should have you come out with at least one reason why implementation guides matter. So I'm going to make sure you leave with at least one reason why implementation guides matter. Is that okay? Okay. So I'm going to ask you to fasten your seatbelts and we're going to go for our ride. We're going to start with foundational resources. Foundational generic resources to FHIR, and there's nothing more foundational than the resource. This is the resource on which all resources are built. All resources inherit the attributes from the resource. This is how we have the instance identifier, the field ID, how we have language, implicit rules, and something called meta. Pull to the side for a minute. Fields in resources can have data types. And you see there's a little, there's a data type here called meta. And on the left, you see a little icon that looks like a cube. That says I've got a complex data type. So when I click on meta, it explodes into a whole structure. So really all of these attributes are also inherited with every resource you get in FHIR. So you're going to have version ID, last updated, the source and profile. See, that's good for from an implementation guide perspective. What implementation profile was used for this resource? Security and tag. So a very important resource is the resource called resource. Also foundational is the resource called domain resource. And a majority of resources in FHIR are built on top of domain resource. And it adds in some additional foundational items, attributes. And two really important ones is text, which is how you can have the narrative for a resource, kind of human readable version of the resource, and extensions, which is how you can have context-specific extensions for this resource, which often happens in implementation guides. Let's say your country adds certain fields into patient. You could do that with extensions. So you'll also notice that domain resource, well, it's built on top of resource. And then most resources are built on top of domain resource. So that means most resources out there are going to inherit the fields from both resource and domain resource. Okay, let's look at some more generic resources that are out there. Not necessarily underpinnings, but generic, such as content management resources. You can have lists of resources. They can be flat, possibly ordered, like your active med list. Questionnaires are really important in healthcare. We're often giving our patients questionnaires, different assessments or surveys. Those can be represented in FHIR with questionnaire and questionnaire response. I'm not going to talk much about that. We'll leave that to Brian. And there's also resources to represent document structure, like composition. Composition is a header for a structured document composed of specific kinds of FHIR resources. There's document reference, which is a header for any kind of document, and document manifest, which allows you to have a collection of documents. Okay, doing okay on the tour? And now security resources. Well, security is really important, and really securing FHIR is something that goes way beyond the FHIR spec, and I think there's a keynote about that as well. But there are specific resources that are published in the FHIR spec that can help with security, such as consent. You know, I can give permission to share my record, or I'm not going to share my record, or I do not want to allow medical care. I recently went through that with a loved one. And permission, authority by which data is shared. An audit event, like I want to know that my data was shared and who it was shared with. And provenance. So provenance tells me kind of who created this resource, why it's the lineage of it, and it tells me why I can trust this resource. I can know really who's touched it, where it's come from. And that lineage also includes something we call the 5 W's. Who, what, when, why, where. And you can find that right in the provenance resource, which we can send along with other resources. But also sometimes those fields, who, what, why, when, where, are in a lot of resources out there. You're going to see the same thing. Looking at resource after resource, you'll see this who, what, why, when, where type fields. Well, when we have something that's common like that in FHIR, it's often put together in what we call a pattern. So we have something called the 5 W's pattern, and it tells you what resources have it. So if you get to know the patterns in FHIR, that's also going to help you understand FHIR as a whole. And you'll see in the spec, you'll say this resource follows this pattern. At the bottom, you see something that looks like a definition of a resource, but it's not. It's a definition of a pattern. It's not programmable. And sometimes a FHIR resource might not follow the pattern exactly, but it'll explain how it follows it. But I encourage you to get to know patterns because, you know, they're a mechanism that makes our spec more consistent. But, you know, in life, when we see patterns, we can understand things in a bigger way, right? So it's really useful to know that they're there. And there are other patterns in the FHIR spec as well. Exchange-related resources are important. And one of our favorite exchange-related resources is the bundle. We have a bundle that we get back when we do a FHIR search, or a bundle that we send on a transaction. Subscription is a kind of a more modern FHIR feature where I can subscribe to resource changes, such as notify me if one of my patients are admitted. And message header is a way that we can send header information when we're trying to do exchange using the messaging paradigm. Often when we implement FHIR, we use the base RESTful interactions, the CRUD calls, right? Create, read, update, and delete. But sometimes we have operations that go beyond that. Some are FHIR defined, like metadata, which is one of my favorite operations because it tells me what a resource supposedly supports, or a FHIR server, supposedly supports, and transaction. And some are implementation guide defined. An example of that would be the book operation to book an appointment, and that is in the Argonaut scheduling implementation guide. So operations need to have their definition, they need parameters, they need the how you can respond. So there's resources to support that. And finally, I want to talk about really quickly bread and butter of FHIR. And bread and butter of standards-based interoperability in general are conformance and terminology. And I'm actually really not going to talk about it because I would say that a good amount of DevDays talks about this. So I'm just going to say there are a lot of resources to support conformance and how we profile the spec for particular use cases. And even the spec itself is developed using these resources. For example, a resource is defined using a resource called structured definition. And that kind of hurts my brain. So that's, I guess, the bread. And here's one of the classes you could go to this week that would cover profiling and talk about these resources, but anything that talks about authoring implementation guides all relates to this. And then the butter would be terminology. And you really cannot do semantic interoperability without terminology resources. I have very poorly circled our terminology resources and encourage you to go to classes about those. Dan Vreeman has one, but there are also other terminology classes in DevDays. Really important to understand terminology and the resources in FHIR, how we use terminology in FHIR. I actually don't usually talk about conformance and terminology as bread and butter because that's pretty tasty and most people will agree to eat bread and butter. I tend to refer to them as the broccoli and cauliflower of interoperability. People ignore them, they don't want to touch them, but they're really, really good for you. So I would say this is the really good food of interoperability that you need to make sure, the healthy food, make sure you consume it. So let's talk about kind of the people, places, things of the healthcare process and get on that. We're going to kind of call that administration of the healthcare process. So we're turning down and going into that neighborhood now, okay? So let's look at people. And probably the most important person in healthcare, I hope, is the patient. That is the subject. Patient is the subject of care. Sometimes patients have a link to other patients, like mom has a link to her babies. Another really important person in healthcare are practitioners, which is defined in kind of broadly in FHIR as anyone that is really kind of supporting the patients. There's many different types of people that we can consider practitioners, of course, doctors, but also quite a few other roles. And then there are people these are people that are directly responsible in some way for the patient. But there are also other people that are important in this context. We call those the related people, related person, such as family members, neighbors, and the spec even says guide dogs. I have a loved one who has an emotional support dog, and I will say that dog is pretty important to that person's care. And then we have a resource called person. Now, what you might think is that person consists of the core demographics that the rest of the people resources inherit, but it doesn't. All of the people resources in FHIR have core demographics fields. Person completely stands on its own. So it's actually not used as much. And then there's another really important person related to a patient. And that is, who do you call? Who do you reach out to? The contact person. You know, whenever you're in a healthcare context, and especially like in an acute care context, they need to know who can they talk to about you. And that contact person is represented directly in the patient resource. So there's a set of fields related to contact person right in the resource. So before, when we looked at patient, we looked at a list of fields and their definitions. We call that the structure view of a resource. So here's that structure view of the patient resource. So I didn't look at it before. Here's the structure view of the patient resource. Set of linear list of fields. And in there, you see down towards the bottom, we have a folder, a file folder, and the FHIR folder is called contact, and it explodes to a list of fields. So it'll explode right out into the patient resource definition. So a little different than a complex data type, which we had with the cube. And you'll also see that the contact, you know, when we have who is this contact, what's their relationship, what's their name, how can we contact them, and there's some more fields there as well that have been cut off on this screen. But we also see a rule, and a rule is that you have to have at least details on how to, you at least have to have some contact details or a reference to an organization. So there's got to be something there in the contact if you have one. So that's the rule. Yeah, there's a bunch of little kind of hidden icons and tags on here. So I'm going to pull aside and look at that. Like that file folder, right, which is where we can explode a whole bunch of fields out in the FHIR spec. Kind of, it's a way that we can, what's that word? We can conceptualize things simpler and then explode it out into detail. So we have those file folders, and we call that a container. And then we also have the complex data types, such as that metadata type. And here we have photo. And then we have primitive data types like Boolean and integer, which seem to be represented by an icon, which looks like an old disk drive. And then we have this weird icon that's the question mark icon. And that's used when this particular field could actually take on multiple data types depending on context. So in this case, for multiple birth could be represented as a Boolean or as an integer. So if the multiple birth, if you didn't have a multiple birth, then you'd probably just want to have false, right? And Boolean's this primitive type that just says true or false. However, if you had, if this birth was a birth of triplets, the integer 3 might be more useful than just yes. And fun fact, I am a mother of triplets. So these fields always excite me.
When you want Q&A, I do have one question here. I think asked about three minutes ago. So
I wanted to do it at the end, if that's okay.
Yep.
I know I hope that's okay, because I know that could be hard for people. But anyway, we got to go down this road though. Okay. So then we also have flags. Now, what are these weird symbols in my FHIR resource? So we have flags such as this summary flag. And that says that if I do the FHIR summary search, and you'll see all the different resources have summary searches, you're going to get back the fields that are marked with a little summary sign. Little fun FHIR resource fact. Another thing is there are certain fields in FHIR that based on their value, they completely modify the meaning of the resource. And a great example here is deceased. You know, and everyone knows that if a patient's marked as deceased, you're going to want to treat that particular resource different than the ones that are live, right? And then another one is a particular resource that has these invariants and rules associated with it. So that's with that letter I. And we saw one of those with that rule under contact. And then there's cardinality. You know, is this field, how many of these can you have? You know, we could have optional 0 to 1, 0 to 3, 0 to any number. It could be, you know, mandatory, you know, required, you know, it filled in all of these possible values. And I promised you that you would come out with one reason why implementation guides are important. So this is a base FHIR spec. And if you were implementing it and you were implementing it and you were implementing it, none of you would be required to have a single value in a patient resource, which seems really ludicrous to me. Like, I wouldn't want to be sending a whole bunch of empty patient resources around, or you send these fields and you send those fields. We're not going to have interoperability, right? So that is one example of why it's so important to implement implementation guides, and implementation guides are going to constrain resources. They're going to tighten the cardinality and say, actually, we do require this field. They're going to tighten the definitions. They're going to tighten how you use terminology and say, use this specific value set. And they're going to extend the resource and say, actually, if you have a patient in the United States, we also have these other fields, race and ethnicity, that we collect. And so they provide those fields. And that's just an example. So that is my one reason. And you can go in the other classes, try to find their one reason. Some more resource reading clues. If you want to know, I have this thing and I don't know how to represent it in FHIR. Well, I will tell you to do what I tell my children to do. When my children say, Ma, I don't know how to do X, I will tell them, did you Google it or did you find the video on YouTube? That's how I parent them. I taught my triplets to drive using YouTube. I can't parallel park. I can drive, but I can't parallel park. Wasn't required in my state, in the United States. And so I taught my kids successfully how to parallel park using YouTube, except that in the beginning, it wasn't working well. And my daughter said, "What YouTube videos did you use?" And I had accidentally used UK YouTube videos. But then we got better. So you can learn these things off YouTube, and you can learn this by just Googling. And if I Google, how do I represent vital signs in FHIR? I bet what I would end up is on the examples page of the observation resource. Examples are great. You just go look at examples. You can find all these different ways this particular resource is used. Really encourage you to spend a lot of time in there. I know myself I'll call myself a retired developer. But when I wrote software, I was just like, give me an example, please. So there's tons out there. The other thing is you're looking at this resource and you're thinking, who the heck came up with this resource? What were they thinking? This design doesn't make sense. Or, wow, I really love this design and I would like to bow down and pay homage to the designers. Or I would really like to help with this design. Well, you can find out who's responsible by looking for that responsible work group. Those are the people behind this resource. And they have meetings and minutes and everything on the HL7 Confluence website. The other thing is resources in FHIR can mature. So they start out like very immature, and then they eventually get really mature. And it's kind of like people. Like in the beginning, people are not really very well tested. They don't know much, but they're easy to change. And then over time, people get really wise. They're much more complete in what they provide, but they're much harder to change. Like it's pretty hard to change my ways at this point. So the maturity of FHIR is kind of like that. So you have ones at low maturity level, like 0, 1, 2, 3, haven't been tested much. Maybe they haven't been tested in a real world scenario at all. And then you have the resources that have really been tested more and more. More developers are adopting it. Maybe it's more in a lab setting like a Connectathon, or maybe it's being used in the field. As you're doing that, the resource becomes higher quality. It becomes more complete, but it also becomes more rigid. So picking very mature resources, and especially normative resources, is a really good deal to know that something's not going to change under your feet. But sometimes getting in at that point is too late in the game. If you want to have an influence on this resource, you're really going to want to start when it's less mature. So look at that little maturity queue, and it's in every single resource, and it's actually on the list of resources on the resource page. You'll see a little number next to every resource. That's a really useful indicator of how much this resource is really used out in the field and how much it might change from under you. Okay, let's go back. Keep going on our tour. Let's look at some more resources used in the healthcare environment. Some more of these nouns. We have the practitioners I mentioned before, clinician of some type, and practitioner role, a role the clinician is playing in context. The service, a category of service delivered, an organization that's somehow involved, a location that's somehow involved, and a technical endpoint. These are all examples of different entities that play a role in healthcare. And then people can be in different groups, different kinds of groups. And there's two different kind of grouping resources in FHIR. There's the group, which is used for a cohort of patients in a clinical trial, a group of patients that are going to group therapy, or a group of birds that have, let's say, bird flu. And then there's a really important group in FHIR, which centers around a patient, which is the team of practitioners that are caring for a patient in some particular context. We call that care team. And now a really important resource that provides context to care is the encounter. And this is also a great time for us to talk about another view of resources. This is the UML view. It's more of a visual model view. And it's a chance for us to look at related resources, because it's really important to understand that no resource really exists alone. It exists connected to other resources. It's a web of resources. that you're sending back and forth across the wire. And when you look at this encounter resource, you will notice these boxes that look like objects surrounding encounter in the middle, but those are not resources. Those are actually just additional fields in the encounter resource. Those are things that would have been represented as a folder, like we saw with contact, but instead they're represented as these boxes. And it's just a way of sort of exploding out additional fields in the resource. But if we don't look at them, we'd be allowed to look at the resource more abstractly. But if you look carefully at the attributes in this resource, which you might not be able to see that well, you'll see that many of these fields have type reference, and they're pointing to other resources. And sometimes they could point to, there's an or choice. It could point to this or that, like patient or group could be the subject of an encounter. And you can see what the encounter is based on. You can see an account associated with this encounter. You could see if this encounter is part of an episode of care, the location at which this encounter is occurring, and more. So resource references are really important. Now let's look at that episode of care I just mentioned. So episode of care, here's the UML view of episode of care. It also references other resources. It references the patient for this episode of care, the managing organization, the care manager that's managing this care episode. But there's one resource that's notably missing in here. It is not referencing the encounters that are being managed as part of this episode of care. And this is common in FHIR. When you see resource references, they often don't go both ways. So you have multiple encounters, one or more encounters that may participate in a particular episode of care, might be part of a particular episode of care, but the episode of care doesn't tell you what encounters are part of it. And you don't have to have an episode of care in FHIR. That encounters are kind of more central. How am I doing? I don't know. So now let's talk about clinical care processes. So with clinical care process, okay, now I'm not a clinician, so clinicians in the room can try to keep me honest. Okay, but I would say that pretty much what happens in clinical care is a clinician is going to assess the patient. They're going to kind of look at the patient, collect symptoms, information from the patient. Maybe they're going to do some tests. Then they're going to, kind of do some diagnosis, and they're going to make a plan of treatment. And then they're going to treat. And then maybe as part of that treatment, they're going to evaluate that treatment, maybe do more assessments, and it's kind of circular. Did I do okay? Okay. No one's getting mad at me, so that's good. So let's think about that in detail. So in that assessment, and sometimes we call that intake, you'll be asking a patient, what problems do you have? And asking them about symptoms. And also ask them about maybe their lifestyle. So you might, ask a person how they're feeling. You might also ask them things like, do you smoke? Do you drink? And record that information, and maybe even some social determinants of health. You might ask about their family medical history. Do they have any allergies? That's really important. And what meds are they on? And so you'll collect that information, and then a clinician will do some diagnostics. One is to probably examine the patient. Right in the office, you're probably going to take vital signs, and then you might order some tests, such as labs and imaging tests. And then based on that, you're going to develop a plan. You're going to evaluate, kind of diagnose and develop a plan on how to care for that patient. And then with that plan, in that plan, you're going to have activities. You're going to order a whole bunch of things for treatment and maybe further evaluation to see how it's going. And then you're going to treat the patient. And these are represented by a lot of FHIR resources. Some key ones I have over on the right. Condition, questionnaire response, observation are all involved in that assessment and intake. Family medical history as well, allergy tolerance, medication statement, and there are more. And then when we want to run those diagnostics, first we have the order, which is the service request. And then we have the actual diagnostics. And a key resource for diagnostics is the Diagnostic Report, the report of something like a laboratory result report or an imaging report, and then observations that are made as related to that, a diagnostic procedure, an imaging study, and then you're going to do some evaluation, kind of get more idea of what conditions this patient has, and then you're going to develop that care plan. And on your care plan, you're going to have the care team associated with that care plan. You're going to have a goal or multiple goals. You're going to have the conditions that you are working on, and then activities, which are going to be orders. And then, you could order, there are many different kinds of orders in FHIR. And often they have the word request after them: service request, medication request, device request, immunization request. And then you're going to treat. And so some resources related to treatment would include medication administration, medication, supply, procedure, immunization, service, supply, delivery. Let's take a step and look at care plan for a minute. I used a tool called ClinFHIR. It's a fun tool to play with to tease out resources and their relationships. And in that tool, I created an instance of a care plan. And my care plan had an author, which was a care team in this particular case, and it had a goal, and it had an encounter resource that was in the context of this care plan, and it was for a particular patient, and the condition we're treating was diabetes, and then there were activities ordered. So there was an activity of a nutritional consult. And you'll notice that, an important part of healthcare is we have orders, and then we have the resulting events that come from orders, such as procedures and diagnostic reports and medication administration and supply delivery. And we could talk about the orders as requests and the resulting events as events. And those all have similar fields. Requests have a whole bunch of fields in common. Events have a whole bunch of fields in commons. And guess what? That's another set of patterns you'll find in FHIR. We call those the workflow patterns. So understand that. You're going to be able to see that a lot of the requests in FHIR look the same. Getting close to my time here. I want to talk about one resource really important in FHIR is observation. It's a pretty generic resource. And observation refers to many other resources. There are many different kinds of observations. An observation could be as big as an autopsy and as small as a smoking status. And a way that we represent a diagnostic report, which consists of a series of observations, is using the diagnostic report resource. For example, a CBC report, complete blood count, has multiple observation components. And what I want to point out is that diagnostic report includes in it a 0 or more observations. So in this case, we're looking at a resource reference in this direction. So observations do not point to diagnostic report. Diagnostic report points to the observations that are included in it. And observations can stand alone, such as smoking status. Okay. We okay? So a little conclusion here, and then we'll chat. As in every tour, I couldn't show you everything. And last night I cut out a few stops I really wanted to go on, but said, no, cut that out, Virginia. We're not going to make it. You can find the complete list in the resource list in the FHIR spec. Also, please look at examples and just search the FHIR spec. Look for that little magnifying glass, and you can search the spec for whatever you want. It's a wonderfully searchable spec. Ask on chat.phir.org and check the resource guide, which is kind of a high-level description about how resources are used in different ways, kind of like what I did today. And also look for existing implementation guides. Before you implement any resource, understand the use case you're trying to implement and look for an implementation guide that covers it. Because that way, it'll be constrained for your use case. And if it's not, there's an implementation guide that needs to be written. So at the end of our whirlwind tour, what did we learn? You should now be able to identify key foundational administrative, and clinical resources in FHIR. You should now be able to read resources better, review and interpret FHIR resources, and explain those relationships between resources. And you know they're not bidirectional a lot of times. And you should be able to give me at least one reason why implementation guides are a good idea. So with that, this is how you can get to me and Q&A. And I'm sorry for saving the Q&A if anyone was stuck on anything.
So if anyone here in Cleveland has a question, you do want to use the microphone so it feeds into the recording and everybody virtually can hear you. Do you have a question? Okay, I'll walk over to you, but while I'm walking, I will ask a popular question that was asked virtually. I find most of the examples on FHIR resources to be much too simplistic. Do you have recommendations for good sources of more complex / more complete examples?
So sometimes the FHIR reference servers have them, or like the Cynthia data sets, but I would take that question and ask two guys, one named Viet and one named Diego, because those are our chief implementation officer and our deputy chief implementation officer. And that's exactly why we've kind of created our implementation division, is to help us answer questions like that.
Hi, my name is Jeremy Zittermuth with U.S. Digital Service. My question for you is around the directionality of references. I noticed that the two examples that you gave for like one reference points to the, or one object points to the other, but not the other way around, like the specific directions of those arrows seem to vary, like in that like one was a part of the whole and referenced the whole, and the other one, like the whole referenced the part, but not the other way around. Are there common heuristics for like which direction you would assume reference, like objects reference each other?
So I would say it has to do with the meaning of those resources. So encounter is really kind of central to care, and an episode of care is a way of sort of managing encounters. You know, so you don't always have care within an episode of care. Whereas a diagnostic report, a diagnostic report contains observations, but an observation, we can have observations that can be kind of on their own, but if they are part of a diagnostic report, they have to be included in it. So it really sort of has to do with the meaning of diagnostic report. Like a diagnostic report doesn't even, it's important to have that. So I really think it's not so clear cut, but it has to do with how that particular work group was architecting this for that particular meaning.
Got it. So a little follow-up question for you. So if, say you wanted to get from one encounter to another encounter in the same episode of care, would you be relying on, say, like a specific profile that defines like an extension on that encounter that points to the episode of care, or some other resource that you might be able to access it through if you wanted to get that other information just from a like single encounter resource? Does that make sense, or would there be a separate?
Or you might query for the episode of care.
Yeah,
and then get the encounters out of there.
If you wanted to use kind of like references as a way of getting from one encounter to other encounters in the same series of like a condition for a specific patient, would you just be relying on, would you potentially add other references as extensions to that encounter resource to kind of point to other encounters, or would you just be relying on the like implementation of your specific FHIR server to do something totally different?
So you could do what you said. The other thing is the way FHIR is developed, right, is we have the 80% rule. We're trying to do what works for most people. If we get a lot of use cases that this really makes sense, that we want to navigate this way of navigating is extremely inconvenient, you might have a use case that should be brought forward. And I would just bring that to implementers, ask how other people are doing it. And by implementers, I mean chat.phir.org, the implementer thread, which I hope all of you have found. It's a way to never be lonely again. So.
Great, thank you.
And you'll get in architectural like battles on that one, which are fun.
Please raise your hand if you have other questions. I do have a couple related to the topic from some virtual folks here. Episodes of care versus encounters. How are they related within outpatient versus inpatient setting?
FHIR is a pretty generic specification. And it really represents how you represent care in your organization, your country. I will say that for me, my understanding is in an inpatient setting, there is one healthcare encounter. It's my interpretation. I know that when I worked with people in the Veterans Administration, they said every time you were transferred from a room, it was a different encounter. So maybe the VA would say an inpatient admission is an episode of care with all these encounters. I don't know. Maybe at this point, they've changed their mind and they would consider it one encounter. So I think it matters in the context here, but outpatient especially, an outpatient episode of care matters because a care manager will say that I want to be watching this patient as they're going through this condition.
Question. If everyone is implementing it slightly differently, what would you recommend when you ingest data from a provider? Do you translate them into your internal representation? Do you leave it as is? What are the rules or recommendations on translating from one file format to another file format?
Okay, so what am I going to say to him? Go ahead. And we have a ringer in the room here. I kept glancing at you to see if you go like, no.
Well, there are some rules around the fixed formats of FHIR, XML, and JSON. There's well-defined rules for switching between those. But if you're talking about, one health provider is maybe implementing one version of US Core and another is maybe on an older one or something like that, that becomes a lot trickier. Frankly, as long as they're on the same base version of FHIR R4, I would often just ingest them into the system, leave them as is, and just recognize some might have encounter diagnosis populated on and others may not. And in those cases where they don't, you may have to do things like infer, well, was there an encounter whose dates spanned a particular a condition, and then can you infer a diagnosis from that because it was created in the middle? Whether you should modify the actual resources going in, sometimes I will do that for things like adding translations of terminologies. Maybe someone has their own local codes, but there's a standard code and I have a concept map that can do that. I might add those, but then you also should be pretty careful and add things like the provenance resource that will say when you updated it, where the original came from, things like that. That's what I think about when I'm, if I interpret your question right.
So what I want to add to that is that starting with an implementation guide really matters versus doing the core FHIR spec. And what you just brought up, which is sad, is there is an implementation guide called US Core, and there's multiple US Core implementation guide, different versions, but then every vendor does it slightly differently. But first thing you need to know is a vendor implementing the US Core? What implementation guides is this vendor even implementing? And you should be able to find that out by doing the metadata operation. But that assumes that this particular FHIR server is doing FHIR in the right way and telling you what profiles it's supporting. But you really should tease that out. Figure out whatever FHIR server you're talking to, what implementation guides is it pretending to support? And then there are some variants between them, unfortunately. But at least with an implementation guide, there's a lot less variance than going to like the core FHIR resources. And doing things in community is a really good idea. Like, it's just a good idea to go out onto implementers chat and just ask people, because a lot of times what I really hate is when developers just develop stuff in a vacuum and they go out and say, what are the rest of you guys doing? And try it on a few of the big FHIR servers out there in production and see what they're doing. And then fight for getting rid of those variations because it's stupid. We need to make the standard more standard, right? Yeah, thank you. Yes.
Okay, hopefully this is still staying on the same topic here. How can you tell if an encounter / episode of care is related to a research encounter in scope of a clinical trial?
So is that you can't?
It's so dependent on how the
In my experience, a question like that about how can you tell if something is related to the patient's involvement in a clinical trial, that's really going to depend on the course, like the source system where the patient is potentially enrolled in the trial versus receiving their care. Not every organization is going to have that information in the same system. And if they do, it's not always even going to be in the same way. So I think my answer would be, it depends. And you really need to understand the context in which you're pulling that data.
And one of the reasons why that question's hard to answer is we haven't done enough work yet on FHIR and how to implement how research trials are represented in FHIR.
I think they should probably do that in the EMR first before you can figure out how to get it in
Okay.
FHIR.
But it's good to know, so this is going to sound like the tail wagging the dog, but sometimes we uncover things in FHIR and then we end up finding we just found a hole in the EHR. I will say that in my own experience, patient request for corrections, that happened. So in this case, maybe by teasing this out with FHIR, saying this is what we really want, we could help the EHRs get more standard. But the good news is we do have quite a few accelerators that kind of focused on research, like Vulcan and Codex. So hopefully that will help bake these. And if you look at resources related to research, you're going to see all those immature flags, that you can tell they're like 2 years old. Any other questions? And how are we doing for time?
So we have about 10 minutes left, and
Oh.
I do have 3 questions
How
from
do I
the
have so much
virtual.
time?
Pardon?
I should have slowed down a little. Let me breathe.
So I have 3 questions from the virtual attendees, but of course, if you have a question here in Cleveland, raise your hand, but I'll go to the next one here virtually. You mentioned subscriptions can be used to notify about a particular set of patients. Is there any way to build complex subscriptions across multiple resource types, e.g., patients on a given medication with a specific lab result?
So I think the answer is yes. I think there's quite some real nice complexity you can build with notifications.
I didn't finish it. Or is that outside the scope of subscriptions in FHIR?
I don't think it's outside the scope. I don't know at this particular DevDays, I don't know if there's a talk just devoted to subscriptions. I forgot when I looked it up, but I know that in the past, what I like to call poor man's DevDays, you can look at the YouTube recordings from 6 months ago, and there should be a nice YouTube video on subscriptions. And there's also a subscriptions thread on implementation. I'm sorry that I don't have that completely, but I know that in my use of subscriptions, we could do some pretty rich stuff. And it wasn't just on patient. We were trying to subscribe to changes in the task resource, and any newly created communication resource. So we were pretty specific in what we were asking for. Gino Contessa is a real expert on subscription resources.
I'll preface the question by saying you can just tell me to read the spec if it's too in the weeds, but it was just a follow up on subscriptions. Does FHIR define, or does it provide any guidelines for how the server notifies the subscribing clients, or is it sort of up to the implementer? Like, is it webhooks, or how does FHIR?
There's a writing. The subscription resource gives you some options. What you want.
Oh, okay. Okay. Perfect.
Oh, good.
There we go.
So you guys, that Tuesday, June 7th is a session on subscriptions.
Thank you.
Think very hard about your hard questions and then go there. You can even post them now so you don't forget.
All right. This one might be a loaded question. Can you talk more about the summary search and fields related to that? How does that work?
So the FHIR server, when they implement the resource, is supposed to provide the ability to return all of the fields that have the summary attribute in it when you do a summary search. That's how FHIR works.
Hopefully this is a little bit softer. In Stu 3, there were some resources that didn't make it to R4. I'm looking at the referral request right now. Just disappeared. I think it got, without going in that specific, what's the mindset when we do versions when the leadership either embraces more strongly a single fire resource or deprecates one? How does that work? Is it just talking it out, or does my question make any sense? Like
Well-
I have a STU 3 that disappeared, or a fire resource that it doesn't exist in R4.
Well, first thing is when things are less mature, there might be like this design really isn't working that right. We think another design makes more sense, and further testing, we've decided this design isn't right. That's part of the maturity. So you have to kind of, if you're in a STU standard for trial use, you run the risk of using something that is going to completely change. Although by the time we get to trial use, there's going to be less of complete change. And also there's that 80% rule, like how much is this being used? I'm sure that a referral is important, but maybe a different way of representing that made more sense.
I failed as a moderator because I thought this went till 2. It only went till 1:45. So y'all
Okay.
got 8 minutes extra.
Okay, I thought I was the right
Yeah.
time.
So there are a couple of additional questions in Hoover Q&A, and I'll work with you, Virginia, to go out and address them.
Oh, yeah.
Unanswered ones.
And
Okay.
anyone else wants to put anything in Q&A, I will go and even provide more detailed answers than what I can do from up here at the podium. Thank you very much.